Yes.
Yeah, yes, I have actually. Yeah, no, thank you for that. Yeah, no worries. He'll come in as and when he can.
We are now live, Chair.
Thank you, Kirsten. Thank you for your help in the background, as always. Good evening, ladies and gentlemen. Welcome to the Adult Health and Social Care Scrutiny Board on the 1st of September. Gosh, where has the summer gone? It seems like we're vastly approaching winter. In fact, I saw some Christmas decorations in the shop the other day, which is like quite daunting. I walked away. I don't want anything to do with it, not at the moment. So a big welcome, everyone, and a special welcome to Robin, Neil, Neve, and various other people as well. So let's go to the agenda. So substitutes nominated for this meeting, and apologies for absence. We have no substitutes nominated.
No substitutes, Chair. And Councillor Ford, we think, is sending his apologies.
Indeed, that's correct. So item number 2, members' interest for members to declare the interest at the relevant time. Item number 3, admissions to the public. It is not recommended that the public be excluded from any items on this agenda. So anyone out there who is listening, you are most welcome. So item number 4 is minutes of the meeting held on the 11th of August 2022 to be agreed as a correct record. I would move those. Do I have a seconder? Thank you, Councillor Hutchinson, and all those in favour of those minutes. Okay, thank you. So item number 5, which is West Yorkshire Integrated Care Board objectives for 2022-2023. So welcome, Robin, welcome, Neil, and whoever else is speaking. John might be speaking on this as well, so we're all welcome. So would you like to, I think you've got a slideshow as well that you're going to talk us through.
I think our Chair, John's going to start, Chair.
Yeah. Thank you, Chair, and thank you, Robin. Thank you for the opportunity to talk to you today. I think probably as it's an opportunity to meet me, I think then I suspect a little bit about me, Chair, might help. Some of you I know, having been involved in the NHS in Calderdale in a number of different roles now for 13 years. So I'm delighted to have been appointed as independent chair. I am supported by 2 other independent members on the Calderdale Cares Partnership Board. And I think I've had roles in the NHS in executive positions previously, but most recently I was the managing director of Turning Point. So the Health and Social Care Social Enterprise, national organisation, supported people with drug challenges through and mental health, learning disabilities, and primary care. So I bring a breadth of that voluntary and community sector as well as NHS experience to the role. And I think it's probably helpful, if I may, to just give you a bit of an overview of the committee. So we are a subcommittee of the West Yorkshire Integrated Care Board. We have authority and delegated permissions for place. We have been formally constituted since the 1st of July, but we met in shadow format before then as well. And the membership of the committee is hugely beneficial to the place that we all live in and spend our time serving, which is that we have trust leadership there, both chairs and chief executives. So that's Swift and the hospital. We also have social enterprise, voluntary and community sector representation there through that. Health Watch are part of that. And of course, those who lead the various commissioning streams within our place. And from somebody who did spend time in both the PCT and the CCG, this feels very different. This is actually about the strength of what we can do together. So I have a close relationship with the chair of the Health and Wellbeing Board, which is of course the council leader. And our opportunity here is being able to do better and do more by doing it together. We have all come out of a particularly challenging time in relation to the pandemic, the legacy challenges of which are still very much with us as we look into more difficult cost of living challenges and the basic necessities of life being under pressure in terms of heating, food, employment is going to come under that pressure, etc. So from our perspective as a partnership board, our role is very much around doing the right things and those that we can through pooled resources, through efficiencies, but actually through working together for the people of Calderdale that we serve. So hopefully that gives you a little bit of context. I am certain I will see you again, and also through the Health and Wellbeing Board. And I think there's a lot to still learn and still discover about how to do this. We are continually working alongside West Yorkshire in terms of the requirements they have, the expectations they have from us, the authorities we have, but also that bringing together health and social care properly for the first time is a huge opportunity, and one that is taken very seriously amongst the board. So I'll pause there, if I may, Chair. And I know that, as you say, there is a slideshow, which is really Robin will take us through his objectives, which, of course, as the place leader, are our objectives.
Thank you, John, and thank you for the introduction. I think it was really most helpful. And just to let you know that actually we are here to be your critical friends. So we always welcome you to Scrutiny. We never want you to go away upset, because actually it's about helping the service and the end user. So it's really good to have you on board, and certainly your background is extremely suitable for the position. So we wish you all the best in that role, of course.
Thank you.
Okay, Chair, shall I follow up? Is that all right? Yes.
Of course, yes, please.
Okay, thank you, Chair. So thank you, members. So obviously you'll know me very well, and you'll know that I'm in this role as place lead since the 1st of July, as well as the Chief Executive of the Council. Just the context of that is that we have 5 places in West Yorkshire. 3 of the 5 of the place leads have dual roles, and it reflects the way we seek to deliver collaboration, cross-organisational work. But actually, there's a whole model of distributed leadership. So it's not just about the place leads, it's about the key colleagues we have across the health and care system. So the Neil's on the call, who was previously the COO of the CCG and is in this new role. It's really helpful. I think that Deb's our Director of Public Health is also on the call, because Debs is a key part of the partnership board, along with the organisations that John has mentioned. I suppose continuity and change are the 2 things I'd say. So continuity of people, but change in how we work, how we operate, and what we think the opportunities can be in, as you know, I don't need to say this, an extraordinarily challenging time for public services and the health and care system in particular. So this is very much not a kind of CCG Mark II, but there are some of the key individuals, and we have a real stability. So the CCG senior team has become the place team for Calderdale. The entire senior team as before. That isn't the case everywhere, but it is the case in Calderdale. And so we have a continuity, but we are working in a different way. And we're working in the context of actually being employees of the Integrated Care Board. And it's really important to say that the model of West Yorkshire is not typical. There are 42 integrated care boards. There are very few that operate like this. And the legal entity is the care board at West Yorkshire, but the delegation is to place. And by default, things happen in place. So these objectives are important. I'm going to assume you've read this, and I'm not going to go through all of it in detail, but I'm just going to pick out a few key points. So perhaps if I don't know who's controlling it, whether it's Bella or whether it's Dan, but if you could move on to the next slide, please, and that'd be helpful just to have a look at the overall objectives of the Integrated Care Board, which sort of set the framework for how we operate. It's possible to move on. Yeah, so the Integrated Care Board is one of the largest in the country, serving a population of 2.4 million people. It's got a mission based around 4 things. It's been in shadow form since 2016. And it now has a statutory status. I hope that the model of this will be that, rather than thinking it's about power devolving up to Leeds or Wakefield or wherever, it actually, because it technically is based, the core team are based in Wakefield, but that actually it's about delegating down. So in the level of regional and national oversight from NHS England will shift more into the West Yorkshire space. So that's kind of how it works rather than the other way around. You see, we've got strong values, and the final one, subsidiarity, I always struggle to say that word, but effectively that means everything starts in place. That's where people get health and care. But there are some things, some exceptions to that. So there are some very specialist interventions where you need to go, like, you know, if you need to go for trauma, if you're in a serious car accident, for instance, if you need cancer care, heart surgery, some specialist care would be in Leeds. You'd go to other places in West Yorkshire for some other intervention and support. So if the specialist intervention, the evidence suggests we should do it once and do it the same way on very clearly defined interventions, or the value for money would suggest that it's much more cost effective to do it in one way. But generally, we do things in place. And the behaviours are reflecting the way we approach all of this across the whole of West Yorkshire. And that we actually work with citizens, with people, see diversity as a strength, and seek to empower from local neighbourhoods. So I'll go through the next slide maybe a little bit more about how we try to realise that in Calderdale. And the key thing to say is that this partnership is inherently aligned to the Health and Wellbeing Board that met this morning, which is democratically led. We clearly have a particular position of strength in Calderdale, and that we have our chair, Councillor Swift, the leader of the council of the Health and Wellbeing Board, is also the chair of the West Yorkshire partnership body that oversees the Integrated Care Board. So we have incredible level of ability to have oversight and influence in that respect. But in essence, we are able to get on with the health and wellbeing agenda that you've previously seen before about the life phase journeys that I'm sure Debs has presented, I know has presented to you in the past with the work streams. And that's where we do the thinking, that's where we do the delivery, that's where we do the commissioning by default. And we work very much with the partnership body on that. So on to the next slide. So Calderdale Cares. So it's very difficult with these complex things to try and make it all line up perfectly, but we want to start from vision. We want to start from the health and wellbeing strategy. We want to look at the ambitions of the whole West Yorkshire system and the mayoral combined authorities. And what we know, and you'll know this, the things that actually enable people to live well, to live healthy lives, are as much caught up in the things that the mayor of West Yorkshire is trying to achieve, as well as the Integrated Care Board: good, affordable housing, transport, safety for women and girls, tackling climate change. They are the kind of things that enable people to live well, to feel safe, and to thrive. But the other context is clearly that there are national priorities, and the NHS, whilst it has a national framework set by the Department of Health and Social Care and national government, and an operational plan which does set some context for us on the money, certainly going into the NHS, the treatment priorities, and the focus strategically at national level. So we have to make all of those things work together to deliver the outcomes for Calderdale Cares, which are as defined there. We've got a partnership agreement. The text is very small, but we've all signed up to this, and our commitment to work together on shared accountability and the money coming into and the focus coming into Calderdale. If you move on to the next slide, please. And these are the principles, values, and behaviours of how we work. I think I won't go through all of these, but I think some of the things I'd say are very important to us. And I say important to everyone, but health inequalities is really important to us, that we challenge ourselves. We work with the strength of our community, and in particular, the strength of our voluntary and community sector, who play a pivotal part in health and well-being in Calderdale. So I'll move on from there, if that's all right. So these are my objectives. I've put them through. Worth just saying, formally, I report to the Chief Executive of the Integrated Care Board, which is Rob Webster, who most of you will know, who has previously been both the Chief Executive of the ICS and the Mental Health Trust, and prior to that was the Chief Executive of Calderdale PCT as well, so knows us very well. We've worked with him for many years, but I also clearly report to the Partnership Board chaired by John. So again, there's a lot of sub deliverables here. There's a lot to do, as you can see, but the core things are get the team established and establish the role of the partnership, and also me representing clearly the position of Calderdale on the Integrated Care Board, the statutory board in West Yorkshire, lead the development of the partnership board and the related forums. So Stephen Cleasby, who was the chair of the CCG, is now the chair of the Clinical and Professional Forum. Very important that we have strong clinical voice, strong clinical influence, and that's all clinicians. And I mean not just general practice. I mean in our acute system, in our mental health system, in nursing, in social work, that all clinical voices are heard. And the key thing with that, I'd say, to summarise all of those points, is that we'll operate differently. There is still clearly a context around us having to commission things, having to go through statutory processes around commissioning and procurement. But the aim is to seek to develop alliances, to develop provider collaboratives, to bring different providers together to deliver better, away from the previous market-based competition model of the CCG and the Health and Care Act of 2012. So some examples of what we're doing on that: we've got a community services provider collaborative that's in place. We have a new provider collaborative that Anna Basford presented on our first partnership board, which is aiming to bring together all the providers around some key themes, which include the climate change, include increasing local pound and social value, include doing some work to improve workforce and come together in a stronger way in the Upper Valley. So that's some of the work we're doing there. The third thing I've touched on, which is about delivering the Health and Wellbeing Board, things you'll know very well: age-friendly, burnt bridges, some of the things that are really important to Calderdale based on the evidence and the work that we've done. Yep, you move on to the final slide, please. So I need to develop the team. We've got an organisational development focus there. We want to ensure that our team is diverse, inclusive. We listen to and enable and support our strong networks. We have a really powerful new disability and long-term condition network, where we have staff with lived experience of long-term conditions, and that their voices are very helpful to us in developing good health and care that listens to people receiving services, as well as with professional skills as well. Safeguarding and quality. So just, if there's one thing you left from this that I'd say is massive for all of us, is attending to quality and safety of practice in health and care, and ensuring that we have rigour, we have good challenge, we have a good relationship with Care Quality Commission. And we're also fortunate to have our chief nurse, Penny Woodhead, who now has been both the Calderdale and Kirklees chief nurse, but is also now the Calderdale, Kirklees and Wakefield chief nurse. So is enabling us to learn best practice and collaborate across those three places. So it's not just Calderdale and the 5 places. Sometimes it's 3 places as well. We work where it makes sense to work best. And the next objective I've touched on, the relationship to the Mayor, as well as the West Yorkshire Integrated Care Board. And the final thing is a personal thing for me, but in my role in West Yorkshire as much as Calderdale, but I jointly lead the work on improving population health and health inequalities with Dr. James Thomas, who is the medical director for the ICB. And that's a particular responsibility. And most of us as place leads have a particular additional responsibility as well. So my colleague, Carol McKenna in Kirklees, has been leading on the COVID recovery and the vaccine programme, and others will have other specialisms. So I think I've gone through that quite quickly, Chair, but hopefully that's helpful. I don't know if you want to take it down. I don't know whether Neil wants to add anything at this point, or we can move to questions, but I don't think Neil's saying no, he doesn't want to. So
happy to move to questions, Robin.
Yeah. Okay. All right. Thank you.
Yeah, thank you, Robin, and thank you for the comprehensive presentation. It was most useful to have previously, and thank you for not killing us with PowerPoint. That's always most helpful. So, Councillor Barnes, first of all, please.
Thank you, Chair. I don't think it's a surprise to see that Councillor Hutchinson and my hands are up first, so there we go. Firstly, I'd like to offer my apologies to the committee for being slightly late to the meeting, so I do apologise for that. I've got a couple of things. I think the first thing I will ask about, and then maybe come on to the second one a little later and allow other councillors the opportunity to speak, is you mentioned subsidiarity. How does that relate in relation to the primary care network? So how far down does it go? And secondly, and this is a key concern that I think we've flagged up on a number of occasions, is at what stage does Calderdale's visions remain primus, and at what stage can they be overridden by further up the tree? Because if delegation is resigned, and if we look at the meaning of subsidiarity, then actually we should be primus in almost everything. But at what stage would that take effect if further up the tree someone said you must do it? And that is against, and that decision or that view will be against what our visions and values were. So two issues: how does it relate to the primary care network, and what is the override, or is there an override, or can we just stick up the proverbial two fingers?
Thank you, Councillor Barnes. Robin, would you like to come back in on that?
I'll start on that question, and John and Neil may want to add. So on the primary care networks, I think so. They are fundamental to health and care in place. They are key to locality working, but they're not. Locality working is more than the primary care network, but they have a fundamental role. There has been a review that you may be aware of, the Fuller Stock Take, which is effectively Rob Webster's equivalent in Surrey, led a national review, which has highlighted the opportunities for primary care networks to play a really leading role in neighbourhood services through health and care. I think the reality is that our networks, and we're not unusual in this, are at different stages of that process. So potentially I'd say that Halifax and central North Halifax, slightly more embedded. The other three are at sort of a slightly earlier stage of that. But all of the clinical directors have input into the clinical forum and the GP leadership conversations that we have. All of them are working with us on the contracts that we have around delivery of primary care. And I think, and I expect to see a lot more collaboration across all the primary care networks in West Yorkshire as we go forward. I think, but I do think it's probably what we make it. I think essentially we're not going to be told, and the style won't be your primary care network has to do A, B, or C. It'll be about the opportunities for different primary care networks to work differently. One of the things I touched on Upper Valley and Dr. Nigel Taylor's the lead there. One of the things we have a real challenge of is some of the geography, some of the rurality, some of the workforce retention issues, and some of the difficulties around lack of good, the breadth of community premises and locations. So there's a distinct piece of work. We're focusing on that. We'll get to the others, and we want to do some discrete work there. In North Halifax, there's some different issues. I mean, there's some issues, significant issues that you'll know around deprivation, access to services. There's some challenges within some of the primary care within that area. So we need to do a different piece of work there. So I don't think that we're going to be on that particular area dictated to. We have to work and develop the relationships with those PCN clinical directors over time, and it's in our hands. On the second point, I'm not going to sit here and say there'll never be a time when we don't get a directive, either from the ICB, the region, or the national. What I will say is that the culture and style of our West Yorkshire partnership is to seek to offer a robust challenge, to seek to manage that. And I think, to be fair, that's true of the regional directorate as well. But we are in a national political environment, in a very highly pressurised, very public, politically sensitive area. You'll know, the whole issue around the recovery from COVID, issues around GP access, issues around A&E, issues around, ambulance service. You'll know all of those challenges. So there are going to be times when we'll get quite strong requests for us to both provide information, to focus our resources and act. We will seek to manage those. And I'd say almost the role of the place lead is actually to be acting a bit of a buffer, that we'll not just be subject to that, but we'll be able to influence it and shape it. And the best way we'll do that is by getting on with the job and delivering the outcomes. And what we're seeing is this early days, and there'll be a future point. I'm sure you'll want to hear from us more about this. But there's early indications, I think, around some of the performance issues that are significant across the country, that the way we work is actually leading to better performance outcomes. But it's going to take some time to demonstrate that evidence.
Sorry, Chair, can I just come back on that, please?
Of course you can, yes,
Robin, what I'm hearing is the fact that despite all these promises that place has priority and place is primus, is in effect, it isn't.
Is there
because someone further up the tree can make a decision and we have to do it. That's what I'm hearing here. That is the complete opposite of what we have been promised for since I've been on this committee.
Is there a sort of area of service where you're hearing that in particular?
I'm just asking the question, Robin. I'm just asking the question is that we have been assured on this committee that place had primacy and that place decisions for Calderdale would be, that's where decisions will be made. What you seem to be saying here is not what we've been told at previous committee meetings and previous scrutiny meetings. That's what you're saying. That's what you're saying here, and that's a concern that this committee has had on a number of occasions. That Calderdale's visions and values could be overridden at West Yorkshire level, not at national level, at West Yorkshire level. What you're saying there is that is possible, and that is not what we have been assured at previous meetings.
I mean, I don't know if I'd say in terms of our vision, our values, our approach, the way we operate is incredibly consistent and in line with how West Yorkshire seeks to operate. There isn't a big difference. Actually, it's not like we've got a set of values up there in West Yorkshire and we're trying to do something entirely differently. So if you look at the slides that I went through, the values, the visions, the approach is very, very consistent. I can't think of any example, and I certainly haven't been, and it's early days, and I have said that there will be times when I think there'll be a national directive, and sometimes, generally, that makes sense. The vaccine program was incredibly command and control. That was incredibly command and control. We all, for very good reasons, we were in a crisis. We had to act, and we shifted resources, we shifted focus, we moved people, we deprioritized other things, we moved staff and resources, and it was nationally directed, and we had no choice. I don't think any of us raised a concern about that. So there are moments when actually that is appropriate. I haven't had a single occasion so far, and it's only, 2-3 months in, where I've been told you've got to do X, and that's fundamentally different to Calderdale. And that actually, to be fair, I can't remember that in prior to July either as CCG chief officer. So, but I'd welcome examples of that where that's heard. There are times.
Sorry. I think where we're coming from is that Calderdale is in a position where we are the smallest, by far the smallest of the local authorities that form this, and that there's always been a concern across the piece, not just in terms of this, but in other areas, where the sheer size of Leeds and Bradford dominate, and that resources are placed in towards Leeds and Bradford, leaving us as the poor cousins. And we can cite, and you are aware of other instances where that has happened in the past. Now, if we look at some of the highways issues we have, and the A629 is a prime example, where we have definitely fought above our weight and won well above our weight in those situations. But as we're getting into this, and this is a concern, I think this committee, and I said it is a concern that the committee has, and and it's pleasing to hear that you're saying that this has not occurred. But I think we have to flag up as a committee that we at Calderdale need those assurances, because otherwise, and I think it's just down to size. It's down to that fear that both our size and location work against us when we're talking in these regionalisation programs or nationalisation programs, and that is a concern, Robin. It's not meant to be a criticism of individuals of that, but we have to flag up as our committee, as a scrutiny committee. We have to flag up this, and we have to make sure that our voices and our voice are heard well and clear. So I appreciate that, Robin, and sorry for interrupting, but you see where I'm coming from.
I absolutely agree with that concern, and it's absolutely legitimate, Councillor. And so two very quick things. I know others want to come in. One thing I say is, ultimately, it's similar to West Yorkshire, and I'm in both sets of conversations. There are 5 of us in the room, and then there's the core team. So the 5 of us have equal voice, and we have an equal ability to influence. However, the support and infrastructure behind me is not the same as it is in Leeds or Bradford. It simply isn't. And sometimes the expectations are the same. And I will assure you that we are making those points very strongly. And part of the solution to that is saying that this needs to shift some resources into Calderdale to make it work. But sometimes the solution is collaborating with other places. We do have a number of joint posts. Sometimes we can do this with Kirklees and Wakefield. We don't always have to do it in place. Clearly, we've got a shared acute footprint with Greater Huddersfield. So we need to be pragmatic, but we also need to make that clear that those resources need to flow, because there's a critical mass that we struggle with. So that's absolutely right. Yeah.
Thank you, Robin, and Councillor. Thank you, Councillor Barnes, for the question. I think it focuses our attention as a scrutiny to actually, call things in where we think there's issues and where there's potential problems moving forward. So, Councillor Hutchinson is next, please.
Thank you, Chair. I must admit I share Councillor Barnes's concerns, because over decades of working the NHS, I know from experience that the setting of priorities and whatever limited resources are associated with those priorities has been very much a top-down process coming from the Department of Health, and everyone has to jump all the way down the line to meet that priority until a new priority comes along and everyone forgets the previous one, moves on to something different. So I really would like reassurance that it's not going to be one-way traffic as before, but that we have the ability to set priorities at a local level. I would like to take Robin back to the Fuller Stocktake report from May and the role of primary care networks. Just to refresh people's memory, these were set out in the long-term plan for the NHS as the fundamental building block of primary care services to populations of between 30 and 50,000 people, each of which has a clinical director and a designated single fund through which all network resources are supposed to flow. And there are 5 primary care networks in Calderdale. The Fuller Stocktake report states, to ensure that primary care and the views of the communities it works in are heard throughout systems, integrated neighbourhood teams should be well linked to and represented on all place-based boards. The connections integrated neighbourhood teams will build both with their respective communities and between them will be invaluable in the planning and decision-making that happens at place board. Well, I'm afraid I struggle to see where these networks feature in the structure of Calderdale Cares. I recognise that it's a clinical professional forum and a representative from, or the chair of that, sits on the board. I know there are 2 GP representatives, but that's not really the same as representation of the primary care networks on these place-based boards. Am I missing something? Are they there, but I haven't seen the Gantt chart?
Robin, would you like to?
Well, I don't know whether give someone else a chance to add to my response on this. I don't know if Neil
come in, Robin.
Yeah, just.
So I think you are right, Colin, that they are the building blocks. But at the moment, whilst they're in the building blocks, primary care networks are a contractual agreement. They're optional for primary cares and individual practices to opt in. Fortunately, across Calderdale, all of ours do opt in, and we have a good network of directors. So whilst they're involved in the development of the Calderdale Cares Partnership Board and membership, there is an agreement for our LMC to be represented on the partnership board. However, below that, we have our community collaborative partnership group, which I know you used to love the acronym of 3CPB. I know that was a nice one of Mike's, which is chaired by clinical directors from the primary care networks, and all 5's a member of those. And they are members of a significant amount of other working groups across the piece. So we don't just have sort of the clinical forum as our one place for general practice. Our clinical directors are fundamentally involved in all of our pieces of work and a prime partner for the partnership board and the delivery of everything we've got to do. So they are there. They're not there as a particular seat at the partnership board, but primary care is represented through 2 GPs and the LMC, who feed back to their clinical networks and our primary care network partners.
Can I just come back on that, Chair? Because, you know, that does seem to be, I'm concerned that at place level, we're not going to get the kind of granularity of information flowing both ways if it's done through too many intermediaries. And, you know, I really, if they are so fundamental to this development, provision of integrated services at Calderdale level, I would really hope that we are working very strenuously to actually bring them into the board, you know, the place-based boards, rather than just having a representative who is supposed to be sort of collating
this has been done in partnership with them, Colin. This isn't us excluding general practice or our clinical directors. This is recognising the demands on their time and the amount of work there is on integration. So clinical directors are only reimbursed through the national contract for a certain amount of time. So they have to then prioritise what they do and don't participate in. So we have regular forums of communication with all practices, not just the clinical directors and the PCNs, to ensure that information is shared and we have that buy-in and move forward. But that is a delicate position that we are dealing with nationally around contracts for general practice or with individual practices themselves. PCNs are an enhanced service which they have to sign into and are in their infancies with regards to services. They don't control everything with regards to primary care and community, but we do want to develop community services with them there. So we are, you know, working with them, and I can assure you they're fundamentally involved in the majority of the work that we do.
Can I just ask one more question, then I'll quit. But in April 2023, commissioning dental services will be transferred from NHS England to the Integrated Care Board. What part will Calderdale Cares play in the commissioning of dental services in Calderdale? Or is this going to be done at a West Yorkshire level? So how is it actually going to work in a few months' time when it becomes a reality?
Neil, would you like to come back in on that? Oh, Robin, you're on mute, but if you'd like to come back in.
Apologies. Neil will want to answer this because he's quite heavily involved. So
I don't have a direct answer for that at this moment, Colin, because we're still going through all the due diligence work with NHS England to understand contractual arrangements, budgets, needs assessments, and that, so that we have a fundamental plan that addresses all concerns for West Yorkshire. So given the scale of this and considering that each place has issues around dentistry, each place is involved in the development of the model that we're putting in place. Now, I can't guarantee that we'll have pre-CCG PCT arrangements where we had local dental commissioning teams because the capacity just isn't and the money isn't in the system to have there. So I think there will be very much a hybrid between West Yorkshire and place-based information to ensure that we've got consistency across the 5 places and the needs are met. But a lot of work has got to be done between now and March to ensure that, you know, as an ICB, we're really clear, we understand the full risks and the opportunities that are available with regards to the budgets and the commissioning and contracts that are in place.
Good luck.
Thank you.
Thank you, Neil, for answering that. Councillor Kingston.
Thank you very much. I just want to look into accountability for delivery of these objectives. which they look like great objectives to me in one sense, and in another sense I was attempting to find, I come from a teaching background, and in a teaching context, an objective is a measurable outcome. It's a statement of an outcome that will come from the delivering the aims. So I was a bit confused because I wasn't finding outcomes in these lists. How are you going to make these objectives measurable? How is your success in delivering them going to be measured? And how are you made accountable for delivering them?
Neil, would you like to come in on that?
Well, I'll probably, it's probably my objective, so I probably should answer that, Chair. It's a good question. So there's a very clear line of accountability, which is both to the place-based committee to which I serve, but then informal structural line management terms to the chief executive of the West Yorkshire Integrated Care Board, to which I formally report. So that's the line of accountability. The aspiration of this is to effectively seek to establish the partnership, the priorities and the structures around Calderdale Cares between now and March. The intention from that is then to, once we have the operational plan in place, once we have the effectively the full year 23-24 delivery plan for Calderdale Cares partnership, that will set out much more specific deliverables for the next financial year. So effectively we've done this in year. So the focus of this is really to, my short summary of this would be get it up and running, make sure it links into the health and wellbeing strategy, the health and wellbeing board, help the team to get into the right place to be able to deliver this, and make sure that we're doing that in a way that's delivering the objectives and strategy of the Integrated Care Board. The other challenges, as those on the Health and Wellbeing Board or anyone who watched it will know, is that we're doing this in the middle of the time as the whole strategy of the Integrated Care Board is being refreshed. So there'll be a new 5-year strategy with much more specific targets, a new operational plan delivered by Calderdale Cares, and it'll be much more specificity. And you will see performance reports going to Calderdale Cares Partnership Board that will outline progress against that.
And just a follow-up question about how much is patient experience going to be included in this accountability?
Yep.
So are measures of patient experience and actual improved outcomes for people in Calderdale going to be part of the assessment of how well you've done at implementing these objectives?
I would say, rather than patient, I would say people's experience, community experience, of which a part of this will be potentially sometimes being a patient of health services, but actually being a resident and a person who lives in Calderdale is the start point. So there's a number of levels that will work. So in place, we have the role for Health Watch, formerly sit on the partnership board, formally represent the voice of people that use health and care services. We will have a focus on a story and an account and an experience of the health and care system at every meeting. The next one we're doing is around children and young people's experience of health and care. We'll have a citizen story. In the evaluation of the interventions we make, the commissioning is moving ever more towards public surveys, citizen response and feedback. So we're developing that as we go on. And at the West Yorkshire level, there is both lay members that represent our communities, but also there's a separate board, basically a citizen board for West Yorkshire, where people are going to be nominated to represent users of the system. And that's in development now. So that is all being put into place. So it will be through individuals representing communities of interest, Health Watch representing people that use the system, but also we will connect into lived experience through citizen stories every time. That's led by Penny Woodhead, who has a very strong focus in the quality and safety work. I would say inherently through it, you will see accounts of people's experience of the service, and you will see that as being a constant challenge. And potentially at times that will include matters around safeguarding, as well as issues around people's actual, the amount of people using the service and patient feedback.
Thank you, Robin. I think my concern relates to capacity as we're moving into some challenging financial times, the impact that has on people's health and well-being. So I suppose the question from my perspective is, what are the financial challenges that we're facing? Because it's not been easy times anyway. So what are the next potential financial challenges that we foresee?
I'll start, but I'll try to be brief because I've said quite a lot. So I absolutely share that concern, Councillor. I would say there are two big challenges, and actually, probably 2 or 3 years ago, we'd have been talking, or 4 or 5 years ago, we were talking about the money challenge, which still exists, of course, and is significant. Public services and resources are tight. There has been real terms increases in health and care. We clearly know that there'll be a change in government to follow potentially a new Secretary of State. We know NHS is a priority, but then so many other things are. And so we wait to see where that plays out. I would say that workforce, though, now is as equal, if not a greater challenge. So it's not just about the ability to resource our services, but actually to have the level of skill of the workforce. So just I was just checking on this. This is national, not local, but you'll know it reflects in local experience as well. So there's in the last 7 years, there's 1,800 less full-time GPs in England than there was in 2015. That's the net figure. So we've effectively lost 1,800 GPs. Now, as you'll know, a doctor you cannot train a doctor overnight. These are major. These are going to take a long time. So we have 132,000 vacancies in the NHS. 46,000 of those are nurses. So I could then talk to you, and I won't, but about social care, social workers, children and adults, and all of the pressures that I know you talk about a lot. So it's for me the number one worry and concern, and we are doing a lot of work on that, but these solutions will not be easily fixed because we do not have the pipeline of skill and trained professionals coming through at the pace we need.
Thank you, Robin. Councillor Barnes.
Thank you, Chair. I just wanted to go back to something, Robin, and I think you would be shocked if I didn't make reference in some way, shape or form to this. And I think it goes back to the point, your answer to Councillor Kingston's comment about the how we're going to consult and surveys. I think my concern is that currently very few people know what to make these comments known, and you in particular know on one particular issue that actually it's councillors who they approach, through whatever mechanism they use. It is councillors and residents, patients, users of the service aren't aware of the how they can have their say, how they can have their voice. Voice seems to be a word I'm using quite a lot tonight. How they can make sure that their voice is heard and their comments are felt. So in a lot of instances, they will refer and speak to councillors, and that's in a large number of instances their go-to, which none of us are complaining about that, but all of us who are councillors in this room are aware of the amount of casework and the amount of emails and the amount of messages we get on that. How is that going to be? How is that going to be communicated to people? How is that going to be so they're aware of the right mechanisms to use, is councillor feedback going to be built within those parameters, within those processes that you're talking about? Thank you.
Robin, would you like to come back on that, sir, please?
I will, but I don't know, other colleagues may want to answer this, and that may include Debs as well, because she's doing a lot of work with communities. So I do think my initial thing is it's not a bad thing that people are going to councils. I know it's probably creating a workload for you, but it reflects the value and role that elected members play, and the importance of elected democratic voice in health and care. So as a principle, I believe in that, and I think that's important. I would say that's probably not universally the same across Calderdale, and it's disproportionate potentially in your ward, I'd say, and that's you've got those relationships, and that's very, very, very live. I would say though, if our lead from Health Watch was here, that she would say it's not necessarily the case that people aren't seeking help, seeking advice, particularly if they're experiencing the service. We do also have we've got a very comprehensive community engagement strategy around people with long-term conditions, people with particular complex needs, with chronic conditions, pain management. We've got a lot of very strong and I think a really impressive voluntary community sector that serves that. We're just establishing, as you may have seen, a community group around long COVID. We're one of the first places in the country to do that. I think it's something like over 1,500 people that have approached us. So I think people with particular challenges are finding ways to access and get their voice heard. I think there are others, particularly, and I'm thinking of Neve here, that some of the people in Neve were potentially not so well. Some of the people that actually do really suffer the most complex needs.
Robin, can I just come back?
It's a lot harder.
The people who are contacting us aren't those aren't those that fit that criteria.
I know you know.
I understand. I'm just, my point here is, how are we communicating that out so that somebody who has an issue with a service knows immediately where to go to? That's my point. Or if they come to a counsellor, are you going to take that as an acceptable communication means for the person? So these aren't necessarily, I appreciate hear what you're saying. I do think in Calderdale we do have some really good links to communities and to those who suffer, those that have those long-term and serious pains. It's the ones that fall in between the cracks that I'm concerned about at this point. Makes sense. Yeah.
So, that's right. I know Debs will come in and add to this. So I should have been clearer. There, in terms of the general population, I was talking about those. They particularly approach you as ward councillors, particularly in your ward in Calderdale. I'd say that's variable across Calderdale. I would say that there are points in which that is helpful. You can always come to us. I think there are specific situations where an individual may need to use a complaint mechanism, a complaint process, and that will have an impact in terms of them getting their voice heard and getting a response, and we can assist with that. There are other cohorts with either long-term conditions where there's lots of support, and then there's a third group that are really maybe the forgotten and where all the work around burnt bridges was done, and that problem has not gone away at all. But I would also say there's a dedicated, it's a very small team because we're Calderdale, of course, a dedicated team work on all forms of communication engagement, 2 or 3 colleagues all of the time to improve understanding and engagement. But I will, maybe if that's right here, maybe Debs might want to come in because Debs is working very closely with the team as well as other colleagues. So I know she can add to that. But we should also not be, we should be quite clear that we've got some really strong interfaith networks, the work around the vaccine, the work around community champions. We've got a vocal and engaged public. I think the point is some of the people that we really worry about are some of the people that aren't potentially able to or able to use those mechanisms. But I'll leave it there, Chair, and maybe Debs might want to add to that.
Thank you, Robin. Just before Debs comes back in, I just want some clarification in relation to the complaints process that hasn't actually changed from the general public. So if you'd like to come back in, Debs, it'd be most helpful. Thank you.
I can't answer the question about the complaints process. All I was going to say is that there's a fantastic group that sits under the Calderdale Cares Partnership work that looks at communication, engagement and equality, and that brings together partners from across the Calderdale Cares Partnership, across the health and care and wellbeing system to sort of coordinate and champion engaging with, listening to and communicating with our communities. And what I would say is it isn't a one size fits all. So the work that happens, we don't just rely on people coming to us to tell us things are wrong. We go out and invite, if that makes sense, through lots of different ways, invite people's feedback and involvement. So, and some of that is through really making this the way we work, making two-way communication, listening, engaging the way we actually work. And Neve will talk a little bit in the presentation that she'll give later about some of the work that we're doing with people that have got really, really complex and multiple disadvantage. But Just to say, I just think there's not one size fits all. We don't just wait for people to come to us. It's about making this the way that we deliver healthcare and wellbeing in Calderdale. I think there's more to do, but I think we've got a really good partnership that's working on this, and we've learned a lot, as Robin said quite rightly, from the pandemic as well, about what really works in working in this way.
Super. Thanks, Debs, for that. Neil, do you want to answer my question about the complaints process?
So the complaints process to us as a commissioning board is no different under the CCG. We have a change of email, which I believe a significant amount of publication has gone on the various sort of websites and social medias and sort of in accessible format for people. So we still required to respond within certain days, and we will still involve partners and act as an advocate where it involves multiple providers to respond. Interestingly, we didn't see a significant increase in last year's statistics. We saw a significant increase the year before, sort of post-pandemic, but this last 12 months, it's settled to pre-pandemic levels and in consistent areas.
Thank you, Neil, for that. So, Councillor Hutchinson.
Yeah, thank you. Referring back to Robin's point about the workforce issues, it's great that is now being acknowledged everywhere, apart from at the very apex of our health systems. But I do appreciate that it takes 10 years to train a consultant from scratch, but there's many other disciplines which take much less time. And given that one of the major issues of accident and emergency departments getting clogged up is because people can't be moved through the hospitals and then discharged back to their own homes, I was wanting to know what we're doing locally at Calderdale Cares level to stimulate and to facilitate the training of social care workers. Particularly, I believe that the home care workforce is under very strong pressure, and that is one of the reasons that people are finding themselves stuck in step-down beds in care homes, rather than being looked after and assisted and re-abled in their own homes. Similarly, I've asked for a number of years about our strategy for district nursing, where the numbers have shrunk incredibly over the last 15 years, when we really need people who are fully trained and good clinical decision makers and able to work independent, off their own bat, off their own initiative, in patients' homes, and that these are people, nurses who can be trained down the apprenticeship route from a qualified nurse to become a fully qualified district nurse over a relatively short space of time, a year or 2 years at most. So, we need to be at least making a start on addressing the workforce problems, rather than saying, well, it all takes too long. So I was wondering what is going on, what can Calderdale Cares do to deal with the local workforce issues, where, starting with the things that can be done quickly.
Can I comment on that, Chair?
Yeah, please.
Yeah, Neil, you go in. But can I just, Neil, before you do, just say, please don't think I'm saying we can't do anything about it for many, many years. There are many, many things going on, and we're acting now. But Neil will want to add to that.
Yeah, so I think this is an area, as a partnership, we want to sort of formalise and crystallise all the plans and the good work that's going on, Colin. So we have a workforce network across Calderdale, and it does cut across into Cleasby as well, recognise our main acute provider. That involves our community providers, it involves our clinical directors, to ensure that we've got a plan particularly somebody for those clinical roles, as you've alluded to, take a long time to come through. But we've been working on this for some time. The additional roles within general practice has been funded and is about creating additional non-clinical roles to help with that workload. And we've actually had some success recently with the Urgent Community Response Programme, which is a new service offering which required 11, I would say, sort of social care background or the home care market, which actually, in working with partners, we've employed through the hospital trust because it's more attractive and they're able to recruit a lot easier rather than the home care. So we do have examples where there are needs. We are trying to think differently and to try and access different workforces to be able to plug the gaps. And I think that's what we need to bring together over the next 12 months to be able to clear what we are doing, what we have had successes on, but also be real that some of these clinical models, and we've had the challenge here before that people want to see GPs, people want to see nurses, but unfortunately that may change. You may be seeing different professionals to help you navigate around the system. And we recognise we need to do communication around that to make sure people are comfortable and understand those challenges and differences. But there is a huge amount of work going on, but there isn't a huge pool for all these new roles either. So we do work with the college. The college is involved in that network as well to be able to provide training packages so that we get people with different skills to be able to meet the needs in the health and social care arena. Recognising home care is a particular area, but if we can do things differently and get people with very empathetic skills, we are managing to recruit people from supermarkets and others that have skills to be able to deal with people and help them navigate through the health and social care system.
If you're looking after more seriously ill people with complex clinical needs and more people wanting to die at home, you need clinical staff. And this is where district nurses can play an enormous role. And there seems to have been a blank about this at national level as well as local.
There's a blank on a lot of specialties, Colin. District nurses is just one. I think we've alluded to across the whole clinical spectrum there are shortages. District nurses isn't being ignored. It's part of a big mix of lots of specialties that have all got competing priorities, which we will have to balance and develop new models to ensure those that are in post and those that are in training are maximised to the best of their ability and complemented by other skills.
But for that, you need to have the training positions and offer the apprenticeships. And I'm not aware that Calderdale does.
I think we might have to bring the trust in for more. I don't have the detail on that, Colin, sorry.
There is some regional work, Chair, within Leeds around the Health and Care Academy that's seeking to develop a long systemic approach to a pipeline for nursing. But I would just say emphasise Neil's point, district nurses, midwifery, drug workers, the next item we're going to be talking about. Potentially there's a whole raft of professions that this applies to. I think with social care, it's a complex thing to sum up in a simple way, and I may want to add to this, but I think we have a parallel problem of that around social workers, although we now have a teaching partnership that's well established with a range of universities in Yorkshire and Humber, and we are developing an approach to developing the next generation of social workers using some national programs with a number of universities, particularly York, Leeds and Huddersfield. However, it's retaining them as much as recruiting them, and in a very competitive job market around salaries and et cetera, and also retaining them in the particular aspects of social work, like mental health, AMPS, etc. Those with those skills around providing liberty, some of the specialisms within social work that are incredibly challenging because they're tough jobs, and there are easier ways. This is true of mental health. This is a significant challenge around inpatient mental health capacity, because actually you can earn as much, if not more, in community mental health. It's less generally, and I'm generalising here, less stressful. You're less likely to get attacked by someone. There's all of these kind of things. Basically, there's a whole set of challenges around the profession which we're engaging with and trying to deal with. Then with social care, there's obviously points that don't have that kind of trajectory around qualifications, but actually the competitive job market around retaining people with the choices that people have in the job market at the moment. Again, we do have some really good social care providers. We do have a kind of context and a culture around a loyalty to social care provision in Calderdale, which is great, but it's a national problem, as you'll know.
Thank you, Robin. I think that's it's been extremely useful to discuss these different aspects tonight. I think it's something that needs to be kept on our agenda. Equally, I think if you perceive any challenges that you would like to bring to scrutiny, that in a better, further discussions, our door is always open, so that actually we work with you. We are your critical friends. So we want to work and make sure that actually the outcomes are the best for the people of Calderdale with this. So thank you for the report. We do need to bring this back to monitor this and continue to scrutinise the hard work that you are doing in the background. So thank you, Robin, John, and Neil for presenting on that. It's been extremely helpful. So if you would like to stay for the next item on the agenda, you're more than welcome to do so. I do appreciate you are equally busy people as well. So thank you.
Thank you, Chair. I do need to leave, but thank you for the invite. Thank you.
I shall see you all soon. Thank you again.
Thank you.
Thank you, Robin. Yeah, thank you. Right, item number 6 is the National Drug Strategy, developing a Calderdale response. So we have Neve and we have Debs here to present this particular item. So welcome, Neve. It's really nice, always nice to have you back on board and to have you back in scrutiny, and always, of course, Debs. You're always there. You're a superstar.
I think if Debs is going to do the slides, I'm going to talk, and then she can do something. If I go left field, she can take over.
Okay, fantastic.
I think, Bella, were you going to do the slides, or do you want me to?
Yeah, I can do the slides.
And we'll try not to kill you by a PowerPoint. And the slides are for you, and I will try and put the meat on the bones.
Fantastic. Thank you for that.
Neve Cullen, I'm Public Health Manager, and the bulk of my work is drugs and alcohol. I've met some of you before. I think it's useful if you have questions to dump them in the chat so we don't lose anything, and then look at them at the end. And I was going to say to Councillor Barnes, headline now, this is clearly top down. There's not been much room for this. This was our outgoing Prime Minister's pet project. It wasn't going at pace, really, and the last 4 months have been absolutely mental. I can only describe the rollout of this as being a bit like in the thick of it, and we've had to meet really, really short timescales and crazy demands. So we've done as much consultation as we can. But what I'm going to try and do is show you where we're at. So whilst it's very much top down, I think what we've done is we've tried to flex and shape it into place as much as possible. So next slide, please. Next slide for me too. Right. So in terms of the drug strategy, the biggest chunk, and it is the first time ever, of money and resource has been aimed towards treatment. There are other elements of the strategy, but they're not quite all being rolled out at the same time. So we're waiting for some potential funds, but certainly direction on education, housing and employment. But the latest I've heard on those is they're very likely to be pilots. So we won't necessarily be expecting any resource. And of course, there's obviously another piece of policing work and world that's also being rolled out as part of this drug strategy. You'll have seen, I'm sure, on the news, a lot of that will be focused at targeting recreational drug users to try and undermine them fueling the market. That's the kind of taking passports away initiatives. But they're also still really heavily focused on county lands and cannabis farms. But that hasn't quite been rolled out at the same time as this. So just so you know, this is treatment we are talking about today. And there we've got the focused investment pushing us back towards partnerships, which some people in the room might remember the drug action teams. It's very much revisiting that, not quite the same, but revisiting it and developing a new national outcomes framework. So how will this be achieved? We've got the focused investment, that huge bit of 780 million being rolled out for treatment services, when we really have been chipping away at what we had for the last 10 years. I mean, in Calderdale, what we've done is we've protected as much as we can on frontline services, but that's why you end up with just me in the most under initiatives. So we lost a lot of our back office support, and we want to improve partnership working and accountability for those outcomes. So the way it's been rolled out, and it's interesting following on from the integrated care board's discussion, is it's been rolled out in waves. Wave one being those local authorities in wave one got the biggest chunk of money first, and then it tapers. Now we're at wave three, and I have to say I'm so relieved. My counterpart in Leeds is having to look at recruiting 30 staff at the moment. I haven't got that headache. You know, we're looking at numbers of around 5 in an environment where recruitment is very, very difficult. But also in the money for the years 2 and 3 is indicative. Things might change. A new Prime Minister might have a different view, or we might not be able to spend that money because of other circumstances. So being wave 3 is not a bad thing. And in terms of our partnerships, and I think this is where I'm trying to tie into the burnt bridges stuff, we're actually in a really, really good place. Operationally, our partnerships are really strong. And we have partnerships now that we didn't have 15 years ago. We have the Mental Health Trust at the table, and we have Adult Health and Social Care at the table, who traditionally wouldn't necessarily have been there. And the other piece of work, just to kind of, that's been running alongside this, they've just published some commissioning quality standards. And that's been I did a self-assessment on that this morning to try and get my head properly in the game. And it's really interesting. We are in a really good space. A lot of what's been asked and a lot of the recommendations in Burnt Bridges really chimed with the recommendations of the Dame Carol Black report. So the areas particularly around health and complex needs and engagement, we're kind of a step ahead. And to give you an example of that, one of the benchmarks is they'll be looking at local authorities spending 4% of their budget on recovery in the coming year, because a lot of areas don't invest. We've got such an established recovery community in Calderdale. We're already at 20%. So lots of the indicators, you know, sort of, we haven't got to change what we're doing. So yeah, right. Here's sorry, I've just moved my slide on. The whole system approach. I think this slide's just really useful to think of the kind of complexity of. So what's happened is this is where the line of accountability is, but a lot of these areas, you know, DLUC, Home Office, it's been a long time since they've worked together. It's been a long time since they have to give up money to the Treasury on substance misuse. So that's been quite difficult. I'd say that everybody's willing to work together. We've got a way to go until all these departments are all talking the same language. I think we've still got to do some of that. And the other thing we're really pushing for is a simplified suite of reporting, because we're really at risk here of having, you know, a bit of money for housing and homelessness and having to, you know, talk to DLUC and then hit about other monies, and it really would become unmanageable. So we're working quite hard to feedback centrally on that. So if we look at the next slide, I think, Colin, this will be what you're looking for. So on the left-hand column there, that is the headlines of what is going to be achieved with this new money nationally. So what we've done is we've worked out what that looks like for us locally on the right-hand side. And very achievable. The second point there, which again, for those of us that are still working and interested in the Burnt Bridges work, where we've monitored deaths before, they're monitored by coroners' overdoses. It's drug poisoning or overdose very clearly. And of course, what we understand now locally in Calderdale, we have a huge amount of people who use drugs dying under 50, but it's often not overdose. It's often sepsis. It could be COPD. We have an awful lot of suicides. So by monitoring deaths in service, that work will be monitored as well. I did a little, I just looked at our last 15 deaths in service just to check that I was saying the right thing. And only 7 of them were opiate overdoses. 1 was a suicide, and the others are yet to be confirmed by the coroner of other causes. So it will help us to dig down and understand those things much more. So here's the local history and context. I mean, as I've said before, we've worked with reduced budgets and a lack of focus, but we've continued to work operationally together. We're in line with the Carol Black review. So some of the things, just to remind you, that we've done that they will be asking for has been housing and drug users at Craven Mount, the rollout of naloxone. Now, naloxone is a drug, an antagonist that if somebody has used an opiate will bring them back to life. It's that kind of Pulp Fiction, jab them and they're back again. Unfortunately, it doesn't necessarily work for all the drugs our community are using. We've got now dedicated multi-agency meetings, which is like the where we look weekly at those people that we're most concerned about from across the system. We've had a harm reduction renaissance in terms of we used to talk about hard to reach communities. I think we understood that we didn't go and find them. They're not actually that hard to reach. We just need to go to them. And we're reaping lots of benefits there. And a lot of that I'd like to talk in another closed meeting about is our hotspot and place of concern work. But we are still limited. And I can make available to you, I couldn't work out how to do it on the slides, but we have planned over 3 years where we'd like to spend the money, and the money does increase in year 3. And we need to be able to test drugs effectively. We need to look at safe places for people to be able to use drugs. I'm looking at new treatment options. So we've put those aspirations in year 3, and they've all been accepted by central government, which was interesting, but some of them aren't quite legal yet. And again, this gives you some idea around where we are. So these measures here are national measures that are just drawn from data. And if you look at the first 3 there, where we're amber, they're very obviously red, green, and amber. Those are the successful completion. So the measure that we're working with to date has been that somebody has to leave treatment, stay out of treatment for 6 months to be considered a successful completion. Well, there's been lots of problems with that. One is it doesn't quite capture the journey and the incremental benefits and gains people make along the way. For example, being able to rely just on their methadone script and not using crack on top, that's really significant. But also there was some gaming nationally, because we're still stuck in a bit of an unfortunate market economy where people were actually not able to access treatment unless they'd been out for 6 months. That was happening for performance management purposes. So there's a big push to change that. So I think we're very likely to shift in the green there if there's a more nuanced approach to it. And they're working on a new suite of measures there. The red for deaths for drug misuse, I can't see that changing anytime soon. And I'm sure that will be the same nationally. The green about moving people from prison, we do that pretty well in Calderdale. We try and pick them up very, very quickly. Part of the money that we were given last year, we actually send people to pick on those vulnerable up at the gate and take them straight to the chemists and get all of that organised. And then the other measures that are red there as well. And I think when we have the additional funding and the more back office capacity we have, that's about alcohol. And we're out of date on an alcohol strategy, and we really need our public health team capacity to look at that and look at what we do with that. And that's a big issue. Our alcohol referrals post-COVID are absolutely huge. And we all know people that's habits changed and have had problems because of that period of time. Next. There we are. So building on the lessons from burnt bridges, it's very much how we've tried to invest the money. So we now have on-site prescribing at the basement project. So what would happen, the nice clinical guidance is that if you miss picking up your medication for 3 days, you basically have to stop and start again from the beginning. I think the average target for waiting times to start treatment in the UK is 2 weeks. But for our most vulnerable, we can get people now prescribed in 24 hours. That fell out of COVID. We learned to do it in COVID, so we haven't stopped. And because we're seeing them on site to prescribe, to dispense their methadone, we can have very long appointment slots. So we can have 10 till 12, and then we can look at the list, and those people we're worried about, we can ring. or we can send outreach workers to find them. So we've massively reduced people dropping off their prescriptions. And now with this new money, we've got a nurse on site. So you're not only, someone will be able to pick up their methadone, but also being asked how their wounds are and being able to assess their wounds or do some primary care nursing on site there. The multidisciplinary team meetings that I've talked about. But we've had some really sort of quite amazing specific cases, really. And I will only talk very lightly about them here so as not to identify somebody. But to give you an example, we had a homeless man whose legs were so poorly you could see the bones, who was not accessing healthcare, was not accessing housing, but was actually working for dealers, working 18 hours a day and sleeping in a rubbish bin. Going to hospital wasn't his priority. We tried several times. He was beaten quite badly. And we worked very closely with the police and we learned a lot. So we learned if the police arrest somebody when they've got a lot of crack and heroin on them, that debt has to be paid by that person to those dealers. So people, it's modern slavery. People end up working, doing 18-hour days for absolutely no money. And we have managed a joint piece of work where instead of seeing this through the lens of the drugs laws, we've approached this through modern slavery. And we've managed, this man is now not in Calderdale, he is in a safe house, he is in healthcare. And of course, the intelligence he was able to share with us as well has had some big impacts for our local policing. We've also, I don't know if Councillor Courtney is still in the room, we've had women reporting rape and serious violent crimes. Unfortunately, Councillor Courtney walked into the disclosure of that, which was having a sort of on-site visit, and women who traditionally would not report crime are now reporting crime. We've also, and out of the most complex cohort, we've managed to have 3 people so far take a week's respite in one of our residential houses with the basement. 1 person's come back again. So in terms of our work, it's sort of the burnt bridges stuff seems to have really opened us up to be able to deliver the drug services that Carol Black aspires for us too. And the other thing I think we've learned a lot. So it's very interesting for me because I've been here 15 years, but most of my career has been in London. And I've never worked anywhere where people are off place. Those poorest people in those those intense housing projects that we know of, they don't come from anywhere else. They're people of Calderdale. You know, they're people of Calderdale, and many of them have been there all their lives, and they've been corporate children at some point as well. So I think I think that helps with the collective commitment for us to address these things. So here's the money slide. I just want to say, I always worry in the local authority when people see £3 million and they must think, oh no, that's such a lot of money. And it's just to remind you that we are commissioning clinical services. It's doctors, nurses, and it's drugs at fluctuating prices. It can be really challenging sometimes to manage that. So we've just about held that stable and kept what we've got. But with the additional, there hasn't been much wiggle room. So the first year's allocation was very much about criminal justice and the lock zone. But this year's allocation has been focused on complex lives and nursing. So again, we've utilised all of that. The line for inpatient detox here will make local councillors unhappy because that has been done to us. We've been given that money by central government. We've been put in a consortia with 5 other local authorities. We have been told where we have to buy the beds from, 2 specific hospital beds, hospital premises. The result of that is that before this, I used to spot, if we couldn't deal with somebody locally, I would spot purchase such placements. That would be a 2-week wait. Now we're in this consortia, the wait's something like 16 weeks. So not everything is working quite as we'd like it to, but we're aware and we're on it. And this is looking at, so this is the 3 years funding. So we know we've got the confirmed funding this year, and that's all spent. And this is the to be confirmed. So you'll see there in year 3 with that significant uplift. That's where we want to do that's where we're storing the more creative and high cost interventions that we want to develop. Sorry, I'm out of time with, can we go to the next slide, please? And again, I won't go through all of these. On the left is very much they call it the menu of interventions that they expect us to spend, and we've met all of those. And I just wanted, for those of you that were interested in the burnt bridges work, what I've tried to do is, where there was a bit of slack, weave those into initiatives that will benefit the whole system. So system-wide training on safeguarding and vulnerable drinkers, which was a weakness for us. Trauma-informed training across the system that works with the complex lives cohort. Community-based alcohol brief intervention courses in the community. We want to deliver them, and we've got people with lived experience who've been trained to deliver those in community centres and a variety of venues. The CCG, as they gave me some of their underspend, and we were able for the first time to recruit a psychologist that will really help. We won't be able to use one psychologist to see a lot of individuals, but that will really help us become a trauma-informed and reflective organisation, and that's what we want to use that for. And we have a new nurse, a new post, because the A&E department have now got a sort of trauma-informed navigator team, so we'll be able to work directly in the hospital going forward. And the hospital have been great. When we look at, not that we're going to have to work very hard to increase our numbers in treatment, but our close relationship with A&E now means I get to see very often what the need is in relation to both adults and young people in terms of substance misuse, and we can find it all there. There's an awful lot of unmet need going through the hospital. Governance, sorry. And yeah, absolutely. So the governance, they've been absolutely clear as well. We've worked locally and agreed with the Health and Wellbeing Board that they will take the primary oversight for this. In terms of the government ask, they did say that a Director of Public Health could be the most junior senior responsible officer. They're very, very keen on this whole thing as being as senior and high profile as possible. We really welcome the additional capacity within the public health team to do this work, and that will make a really significant difference. There will be we will be working to sort of several multi-agency working streams, and we'll develop those as we go, but they're likely to be crime, children and young people, reducing deaths. We've had our plan signed off within the local authority and by the Police and Crime Commissioner, who's taken a very keen interest in the Calderdale work and has been very supportive, and will provide oversight to our local board twice yearly. And that will enable us to learn from our neighbours what they're doing. Key challenges: capacity to meet the bonkers timescales. Some of them will have to be shifted, they really are. They want for example, they want a full robust needs assessment by November. Well, I can't imagine any area is going to be able to manage that. Locally, being a small authority, we're going to have to really work really smartly to work out, to not exhaust people with meeting fatigue, and be really smart. So if I'm talking, I could be sitting in the same room with the same colleagues talking about domestic abuse or other safeguarding matters, other criminal matters. So I think there's some work to do around that. Dual diagnosis is still a challenge for exactly the reasons Robin was highlighting and Neil. The money isn't the issue now, it's absolutely the recruitment. And the downside of being the poorer area in terms of our 5 West Yorkshire neighbours, another risk we have is that some areas are taking, I believe, quite a blunt approach to staff retention and increasing salaries by 10%, which we can't do. Those areas in Wave 1 can. So we're going to have to work really hard that we don't hemorrhage our good staff locally. And then the conclusion and recommendations. I mean, we're coming here to ask for your comment and to ask what role you'd like to play in scrutinising the implementation and delivery of this plan, and what kind of information you'd want regularly. And I mean, for me, and of course I have nothing to do with scrutiny until burnt bridges, and for me it's really important and it's really useful. And the energy and the encouragement I've had from scrutiny has been an absolute game changer in terms of work. And I'd really like us to be able to roll that energy and support into the drug strategy as well. And I'm not sure whether that might be being members of the partnership board. I mean, there's lots of ways we can think about it. But for me, it's please keep scrutinising. Thank you.
Thank you, and that's best I can see everyone now. So thank you, Neve. That was absolutely a wonderful presentation. I think there's some great opportunities to work with you as we always do, as we want to do, and so yeah, I'm sure we'll come to some agreement as to what we want to scrutinise moving forward. So, and we covered the things with the chat. I think. So we've done the Calderdale. Is it possible to add units into the value column of the table outcomes in the line deaths from drug misuse? Is that per 100,000 population or what? So,
right. So the 275 is Calderdale only, Colin. And it sounds a lot, but we're probably halfway there already in terms of our post-COVID pickup. Impossible. I will look at a better way of presenting that. That's from the National Public Health fingerprints, but we could do something better locally in terms of the value. And I'm not going to even try and answer that, if that's okay.
Yeah, no worries. Councillor Hutchinson.
Thanks a lot, Neve. I mean, it's really refreshing to hear of a service that's in the process of development and meeting, you know, is sort of got at least some of what's required to meet the challenges before it. So I wish you all the best in actually developing it. Innovative measures are being taken in various places in the UK that seem to be proving effective. And I know they've been discussed in some detail in Calderdale, but they don't, you kind of hinted at them, but they don't feature in this presentation. So things like heroin-assisted treatment for people whose symptoms aren't adequately controlled simply with methadone, which is being done in Middlesbrough, anonymised testing of drugs acquired on the streets, as is being done in Bristol, and pre-arrest diversion for people found in possession of drugs, as is being done in Thames Valley.
It's a reference. Now, the first thing is, it's year 3 because of the cost. So we're calling it diamorphine assisted treatment because it's a little bit less emotive. But we are looking at that. It's high cost, and we're also looking potentially at we might do that with a neighbouring authority. There might be better value in doing that together. So that's there for year 3. Drug testing is there for year 2 with a different cohort. That's with, if we think of the festival cohort, we want to do something pre-festival. And we have that awful death of that young man at Leeds this weekend, and it's absolutely dreadful. So we want to do that. Drug testing per se and the diversion is being looked at through Alison Lowe, the Police and Crime Commissioner, and the West Yorkshire group, because I think the policing things we work with, we can't just do in Calderdale. They have to be West Yorkshire, and they're going to be allowed to voluntarily carry naloxone as well, and that's another sort of broader issue there. And the consumption rooms, the safe rooms, we are campaigning nationally, and that's the fact. It's the Faculty of Public Health, it's the English Group of Commissioners. The field is campaigning with central government, because at the moment those initiatives are still outside the law.
Okay, well, I'm pleased that they're still there on the agenda. Can I also ask that about sort of the intelligence of what's available on the streets and what's going on? I understand that the centralisation of the coroner's office to Bradford has put barriers in the flow of intelligence about drug-related deaths. But what's being done to establish a better understanding of what's actually being sold on the streets, the concentrations of the drugs, contaminants, and do we have the best possible arrangements for sharing of information between the police, coroner, public health, so that everyone's and accident and emergency departments?
At the moment, there's a few things kind of in play there. In year 2, we're in West Yorkshire, we're collectively going to commission, they're not very expensive, but a surveillance system on the deaths. So we'll be consistent on our asks from the coroner, and we're hoping that will help. The bigger issue, Colin, is the tablets. Counterfeit darknet sold tablets that nobody has any idea what's in them. We had a death on Friday that we feel was tablets. We haven't had a death since January on the street in HX1 that's drug related, and that is a batch of tablets. What we can do, and we've got the police testing route is very slow, but there's an online organisation called Wedanos. So what we do when we can for local information, if somebody's prepared to give us a tablet, we can send it off to Wedanos and they will tell us exactly what's in it. And sort of this weekend, it's pregabalin that's been sold. We don't know if it's fake and we don't know what's in it. So we're trying to get hold of one of those. And then we share, that information is shared through Wedanos nationally, and we're able to share it locally. But it's slow and not good enough. And I think we did look at on-site drug testing, and it's so expensive. You kind of need a chemist. So one of the things we're talking about is whether we do that in West Yorkshire and maybe have a roving test day or two in each of the local authorities. So it's all in discussion.
Okay, thanks a lot, Niamh.
Thank you, Councillor Kingston.
Thank you. I feel like Colin stole my thunder because he asked all the questions that I wanted to ask. Having attended that inspirational day with you earlier this year, sponsored by Anyone's Child, those were particularly the questions that I wanted to ask. So I'll just limit myself to a comment that the experience of that day was particularly powerful for me. And on the back of that day, having spent that day with you, I feel complete implicit trust in you to do your best for these people in Calderdale, and particularly I feel trust in the compassion that's evident in this service, and I really appreciate it, and I'm sure there are many people in Calderdale that appreciate the compassion in that service that you're delivering. I looked at what you want from us, and one of the things you want is for us to comment on how we could scrutinise your delivery of this. Well, I don't know about your delivery of this, but I'd be particularly interested to see feedback, survey type feedback, comments from users of these services. So the people that are receiving these services, if we could have access to comments from them. I think you probably have already set up or got in place a system for receiving feedback from them, evaluation of the service. That's what I'd like to see. Thank you.
That's excellent comment, Councillor Kingston. Equally, I think involving other partnerships like the basement projects and getting information from them. The one question I have is making sure that you have the support as well, because actually it's a very stressful job that you do. Yeah, it can be quite emotionally draining. And I'm concerned and want to make sure that you have the right support in place, that you can turn to someone when there's been a very challenging and difficult day. So that's my comments to you. I'll bring Councillor Brundell in, please.
Thank you. A couple of quite separate questions, really. Firstly, on the table of outcomes, I know you mentioned that there's perhaps not enough room for nuance as you'd like within those statistics. I was wondering in terms of following up on those. So you mentioned that was if they'd stayed out of treatment for 6 months, I think you said. Is there a follow-up point after that? Is there any statistics on, 6 or 12 months after that, how those people are doing? And perhaps if there's a move from one substance dependence for another, are you seeing people repeatedly coming through, perhaps over multiple years, but for different substances? I like that, and then I'll come back in with my next one.
There's two things about that, really. The measure I was talking about there is what the central government was considering a successful completion, that you had to be out for 6. Otherwise, it wasn't successful. And so what we're trying to say is there might be several things that we consider successful. So we might consider it successful if you don't use on top of your script. We might consider it successful if you're able to hold down secure housing or employment. So that's where we're asking for the nuance. But in terms of in treatment, we follow up at 3, 6 and 12 months where we can. We can't always, obviously, not everybody, we're always able to follow up. But we do see, Councillor Brunton, we do see terrible things. So you do see the escalation. So you see someone at 21 who thinks they're immortal, who doesn't at this time have the capacity or want to change, who might be using ketamine and cocaine, that you might see them in 5 or 10 years' time on crack and heroin. It is awful, and you do see people get worse as well as getting better, of course.
And is that sorry to come back in, is that reflected in those figures in that table? Is that, you know, is the statistics for that people who are repeatedly going through, perhaps one time for alcohol abuse and the next time for?
Oh no, that we would, yeah, that data, that national data is very sort of pretty blunt and basic, and that's literally on who leaves. Our local service data would be able to give a much richer picture of that, and I haven't used that for this. But if you want anything specific, quite happy to.
Thank you. That sort of leads on to my next question as well, in terms of, I know we're seeing sort of a changing nature of drug use, particularly among people my sort of age, mid-20s, a much more casual and normalised drug use, particularly around cocaine. And
cocaine isn't a drug, is it? People, it's become separate to drug use. It's really interesting, isn't it? And a real challenge. A real challenge in terms of the marketed fuels, a real challenge in real sort of health concerns. So people think they're okay, and then they're tipping up with heart problems and mental health problems later on in hospital. We've tried 2 targeted campaigns, one pre and one post-COVID. We're also going to be part of, so the part of the policing initiative will be that if you're arrested in possession of cocaine, you'll have to do, it's almost like, do you remember the old drink drive groups? You'll be referred to us, and we will do a group education session. Because the big issue with people that are functioning and working and using cocaine is they have no idea of the risk that they're taking. So yeah, so that's for that end, and there'll be one for alcohol, I think called Know Your Limit, and I've forgotten what the cocaine one is, but there'll be 2 specific groups post arrest, so you won't be charged, but you'll have to attend the group.
That's very helpful, thank you.
Debs, do you want to come back in?
No, that's answered everything, thank you.
Thank you, Councillor Blundell.
The cocaine group's called Fine Lines.
Thank you.
Debs, would you like to?
Oh, thank you. It was just back on the data. In terms of that first question, Councillor Blundell, just one of the things that so the National Drug Strategy has been based on an amazing, fantastic review that Dame Carol Black did, and one of the things that she did, and I know Robin was involved in that, but one of the things that came out of that review is she was very, very critical of the outcomes that we've been using to judge whether our drug treatment systems are successful. Very critical indeed, and we're not yet so there's work going on to develop new national measures. So the measures that you've got there on that slide are very much the old way that these that success was judged, and she was absolutely right. So there's a whole lot of work being done nationally to get much more meaningful measures of success, but also locally we've been doing quite a bit of work with our public health services, and we're starting to think about how we can look at outcomes that are much more personalised. So it's about achieving a goal. Where do you want to be in a month's time, or for some of our cohort next week, you know, but for other people in 6 months, where do you want to be, and how can we work together for you to get there, the individual and the services that are supporting. And then we measure that. We measure people's, have they achieved the goals, whether that's getting a job or a home or reducing the amount of drugs that they're taking, or even going out and having a walk every day and doing some, you know, whatever those personalised goals are. And I think locally we can make that much more meaningful, you know, because those national measures, even though they're going to be much better, I think sometimes those national measures are about the ability for us to compare ourselves with others and benchmark, but actually locally it's about what difference these services are making for our residents and our communities.
Thanks, Deb. So, Councillor Barnes.
Chair, thank you. First, thank you for the name check, Neve. Appreciate it. Really early on in the piece as well. Secondly, Councillor Kingston should know that Colin's local name is Stealer of Thunder. So you need to get your hand up much earlier than that in order to ask a question.
About me.
Oh, boy. Third, I would say, Neve, it's always great to hear from you. Your passion and commitment, it always shines through when you do these presentations. You always provide a human touch and figure to the data. And you asked what from Scrutiny. Well, I think continue doing what you're doing. And I think really to build on what Deb's just said is that make it local. We recognise that there is part of this needs the national figures and it needs to go through that. And we also recognise what Debs is saying is that there should be an improvement in the measures that are there, but make it local, you know. And I think that's partly what came out of the burnt bridges, you know, and some not necessarily the recommendations for that, but some of the information and data that fed into that. Make it local. We'll always ask searching questions. As long as you recognise it, that all of us here have the same goal as you, which is to improve the lives of people within Calderdale. And that's really all I would say to you going on. Carry on doing what you're doing. Yeah, thank you, Chair.
Thank you, Councillor Barnes. Councillor Pritchard.
Yes, I'd just like to ask Neve if there are any initiatives with regard to the increased use of nitrous oxide on our streets, and particularly with regard to younger users.
It's interesting. Again, it seems to be everywhere, Councillor Pritchard. I was down in Plymouth this week, and there was the street where the nightclubs were just absolutely littered. It seems to be, I've spoken to our young people's outreach workers. They don't think there's an increase. They think that there's been more litter and it's holiday time, and they think that might be why there's more of it. We do outreach and we give information on the risks. We do that via the youth services and also through the schools education. We do the drugs education in schools through branching out. But yes, it's a worry. It's a real worry.
What I'm concerned about is the fact that they're not using the little sparklets capsules for want of better. It's the big smart whip, which is really supplied for commercial use. And you can go online and you can buy it whether you're a company or not. And that's what's concerning me.
Yeah, absolutely. It is. It's great, and it is. We're seeing more of those catering ones than we are the little ones that we used to see. Definitely. We've blocked it. I'm sorry, I can't tell you anything more reassuring. This just to say to you that one of the things I didn't flag here is that from autumn I will really be focusing on the young people's drug and alcohol service, because I feel, and it's not a Calderdale thing, I think nationally we've lost touch. And I think that the profile of young people's drug use is changing. Ketamine's very cheap. They're using things earlier and younger, and I think we need to work quite hard to address that.
Yeah, thank you.
Thank you, Neve. It's been extremely interesting. I have just one element, and it relates to births by drug addicts. Are we reaching out to those people? Is that would that come under a different guise, I guess?
Sorry, could you say the first?
So it's births by drug addicts. So the people who have been a drug addicts and then they've given birth, and the after effects and the support for the young person.
We have a perinatal system. We have a specialist midwife, and we work very close. That's something that's managed to survive the last 10 years without being messed around with or untouched. We have quite a good system.
Super. And the other element is the communications. We're often sending press releases out, but within that press release, I think it's too easy to for people not to report what they see on the streets, and I think we need to encourage once again for people saying, actually at 5 o'clock on a Saturday night, guess what? There's drug dealing happening on the bridge in Brighouse, for instance. So you know full well it's happening, but it's a case of people reporting it and encouraging them to do so, I think.
We've also shifted to try and encourage people to use the email, because 101 is so difficult and laborious. And if we tell people to do that, they often get tired and bored. So yeah, we do encourage that email community.
Yeah. Super. Neve, you've been an absolute superstar as always. We always welcome you to the ball, because as I say, you are extremely passionate about what you do. I'm going to bring in Councillor Courtney first of all, please.
Yeah, just very briefly, I just wanted to echo really what Anne had said about, Neve, and in fact, the whole public health sort of group, Debs and Neve, and their passion and their commitment, and having been to visit sort of some of the projects and seeing Neve in action, it's just, yeah, it's makes me feel like we're definitely on the right track, doing the right thing, and yeah, and it feels like yeah, that we're going definitely in the right direction. So I'd like to say as well, thank you to Neve and to Debs as well.
Yeah, thank you, Councillor Connie, and welcome to the meeting. You've been extremely patient there in the background. You had your hand up. Would you like to come back on something?
No, that was my applause. That wasn't my hand up. That
Sorry,
was just
no,
as a long ago joint commissioner for substance misuse in the days of the drug action team, Neve, I salute you.
Super. Fully support that. When you're sharing a meeting, you're looking out for various reactions. So my apologies on that one. So Neve, I said, welcome. Come back, please come back. Tell us the progress you're making. I think that's, do the job that you're doing. Be passionate about it, but make sure that you reach out when you need the support as well, because that's my biggest concern. So thank you. So that's the end of item number 6. So we're going to the work programme item number 7. It has been circulated, but I know Mike will want to say a few words.
Councillor Black-Rose gives me 30 seconds for this item. So I wanted to remind people about the session on...
You should be lucky to get 30 seconds, Mr. Lodge, to be honest.
Nothing further to add, Chair. I just wanted to remind people about the session on general practice and primary care on the 22nd of September, that Bella has done a great job in getting a lot of attendance coming to it, and we're just working up a programme, and I'll be talking to Robin and Neil and others to make sure we fine tune that. But that's something that the members of this scrutiny board have asked for. They want to have a close look at it, and it reflects some of the early discussion Robin was involved with about members of the public raising issue with local councillors. So I just wanted to give you all a nudge about that and how important that session is.
Fabulous. Every so often, Mike wants to challenge me in terms of keeping to time and doing a 4-hour session, so I can actually make sure I keep to the time. So I will rise to the challenge. Robin, would you like to come in?
Yeah, just sorry to add very quickly. Perhaps we can pick up the point that Councillor Hutchinson made very powerfully about primary care networks, just to make sure that we give due focus to that. And I know we've thought about that, but I think the conversation tonight probably just emphasises that, doesn't it, Mike?
Yeah, got that.
Yeah, excellent. And so once again, thank you, Robin, for taking the time this evening. It's been a great insight actually into the other work that you do that we don't always know about. So thank you for that, and thank you, members. So I will formally now close the meeting so you can enjoy the rest of your evening. And thank you once again for your coming along and supporting and asking the relevant questions. So good evening to everyone.
Thank you.
Thank you, Chair. Good night, everyone.
Thank you.
Thanks.
Thank you, Howard.
Thank you very much. Nice one. Take care.